The broadcast is now starting. All attendees are in listen-only mode.
Good evening. My name is Kim Green, and I'd like to thank you for joining our webinar tonight. All of you will be in listen-only mode during the presentation. This webinar is 60 minutes long. At the end of each case study, Dr. Kraus will open it up for questions, at which time please raise your hand and I will unmute you so that you can speak. And here is Dr. Kraus.
Hi, everybody. Good evening. So welcome back if you've been here before, or welcome if you haven't. This is our third webinar series this year, and as you may have known, this year we built on what we did last year, which was built on different topics, not just a general urodynamic interpretation course, but this is more focused on the different types of problems you may see. So it kind of implies that you may have a little bit of urodynamic background. Hopefully you will. If you don't, that's okay. Hopefully we'll still make some heads or tails. By far, everyone seems to enjoy the case presentations the most. For this talk, I have adjusted it, trimmed it down, to include more cases and a little less didactics. And it's actually for one of several reasons. One is because I know you want the cases. Number two, this is a very hard topic, mixed incontinence. It sounds like it should be the easiest because this is one of the things that, like, the urodynamic guidelines say it's a good thing to do, urodynamics for mixed incontinence. But believe it or not, it actually, there isn't a lot of data on it, and you'll see that hopefully as we go through. So again, thanks for joining us, and we'll try and make it interactive. Last time we tried to make it interactive, we opened it up to everybody, and we heard a lot of background noise, and it just was not very good. So the very last time worked the best. After each case, raise your hand or text something into the text box, and Kim and I will try and keep tabs. Kim, my window's a little closed right now because of the extra because of the presentation. But if you chime in, hand up, or say something, we'll call you at the end. Okay. So hopefully by now, if you've been here before, you know I like to have a little bit of fun. Here we are saying we doctors make a lot of money, but don't forget we spend a lot too. I always thought that was kind of funny, but maybe not. Anyway, so we'll move on. That's the problem. I can't tell if anybody's laughing or not. I'm guessing you're not. So there's different types of urinary incontinence. There's the stress incontinence, which we all know leaks when pressure is exerted on the bladder. You get leakage associated with coughing, laughing, sneezing, exercise. There's urge incontinence, leakage associated with an urge to void, and you can't get to the bathroom in time. There's functional incontinence, where you have environmental issues that prevent you from getting to the bathroom. For example, you had a hip fracture, you were doing just fine prior to the hip fracture, and you get the urge to go, and you know you need to go, and you just can't move quick enough because you're physically limited you have physical limitations being able to not let you get to the bathroom in time. Mixed incontinence is actually one of the more common things that I see, and it's a combination of two or more. Usually it's urge incontinence and stress incontinence. And someone had once asked about fecal incontinence, which if you're a pelvic floor specialist, you do see that as well. We do. I know there's some that may only focus on urinary incontinence. That's okay. If you do fecal incontinence, we tend to call that dual incontinence, not mixed incontinence. So it's a soft difference there. There's transient incontinence, which implies that there was a specific cause, you treated the cause, and actually the incontinence got better. But today we're going to be dealing with mixed incontinence. So what do we mean by mixed incontinence? Again, clinically, their most common type is going to be stress and urge incontinence. Where it gets a little bit more interesting is whether or not it's rare when you see one that's pure mixed, meaning it's equal amounts of urge and stress. They happen plenty of times, but usually, at least in my practice, what I'll usually see is a predominant component of one versus the other. So one may say I leak when I cough and sneeze, but I really can't stand the urge leak because I can't get to the bathroom in time. Or the other way around, I have a little bit of urgency, but I can usually make it there, but when I leak and cough and sneeze, that's what bothers me the most. So when we say predominant stress incontinence or predominant urge incontinence, it usually implies what the patient is saying to you. It's not a urodynamic finding. It's not an exam finding. It's typically going to be more of you ascertain the patient had mixed incontinence and they have one component or the other is more bothersome to them. There are no ICS classifications for this. There's not such great urodynamic classifications for this either. Basically, you identify them urodynamically whether or not you identified stress incontinence on the urodynamic exam and whether they have detrusor overactivity. Now, detrusor overactivity and OAB, they are related, but they don't go hand in hand all the time. What I mean by that is you very often will find patients who have OAB symptoms, including urge incontinence, but you don't see the detrusor overactivity, and that's fine. That doesn't mean that they don't have OAB. They do. So if you don't see urodynamic urge incontinence on a study, that doesn't mean they don't have it. And the same often is true for stress incontinence. So it's a dynamic problem, and sometimes patients will not leak in front of you even though they swear they have leakage when they cough and sneeze. Sometimes they're embarrassed. Sometimes the urethral catheter's causing irritation or spasms of the urethra, so they won't leak there either. So urodynamic classifications for mixed incontinence is I guess nebulous is the best terminology I would use, because just because you don't see it on a urodynamic study doesn't mean it's not there. On the other hand, if you want to classify it, you have to see stress incontinence, you have to see overactivity. Technically, if you want to call it mixed incontinence, you probably should see stress incontinence and detrusor overactivity with incontinence, so DOI incontinence. Again, no ICS classification for this one exists either. And then what do you do for the patients who have, let's say, stress incontinence, but they have overactive bladder urgency symptoms, but they don't have urge incontinence? Are they different? Does that mean we should treat them differently because they don't have urge incontinence? You're probably going to be treating based on symptom bother, not because one is seen on a test versus another. Why do we even care about mixed incontinence? Well, mixed incontinence does, of all the incontinence types, it does seem to bother women the most. From a provider perspective, I'm always worried that I'm going to mistreat one component versus the other. They sure sounded like they had predominant urge incontinence. I did a medication, they didn't get better. I did a Botox, they didn't get better. Lo and behold, they had stress incontinence, and I was treating the wrong thing. So that's one of the reasons why it's important to delineate it when you see it. The one that's underlined, I think, actually probably the more important of all of them, and that is the persistence of one component being perceived as a treatment failure. So the examples there is the patient with, let's say, predominant stress incontinence, but they have urge incontinence as well, and you determine you want to put a sling in the patient. And then they come back and they say, well, I'm not leaking when I cough or sneeze, but I still leak when I can't get to the bathroom in time, so your sling failed me, you're a bad provider. It's not the case. Your sling did what it was intended to do. It treated the stress incontinence. It wasn't intended to treat the urge incontinence. So it's an important thing because when you identify that mixed incontinence is present, to me, it's a counseling point for the patient. It's an education point. I'm going to fix this problem, but you have another problem, and that may still persist. In fact, I have a template on my electronic medical record, and when I hit .mixed incontinence, or MUI, I think it is, it'll say the patient was made aware that she has multiple components for the treatment of multiple components of her presenting incontinence, and that the treatment for one component will not address the other component, and that multiple treatments may be necessary. So I do that by the history alone. However, if I had a patient with incontinence, had a urodynamic study, and they're there for stress incontinence, but I see overactivity too, that's one where I may tell them, look, I'm seeing two problems. We'll treat the one that bugs you, but the other one may still be there later, and you may need to treat it. So it really does help for counseling. If nothing else, it enables you to document it ahead of time that they might have this problem. You warn them ahead of time and they have it, you actually look smart, and that's always a good thing. Women bother more. This was from several studies basically looking at various symptom scores. If you compared women with mixed incontinence versus pure stress versus pure urge, the mixed incontinence pictures seem to just be worse severity based on perception, based on validated symptom scores, based on quality of life. What I just alluded to a second ago about the whole counseling thing, that's what this one really talks to us about. And it'll often dictate how you approach the patient, how you approach the treatment. The other examples are fine too. I've had patients with urge incontinence and stress incontinence. They want to get treated for the urge. They don't get better with medications. And then the question is, should you be pursuing a more aggressive urge incontinent pathway? Like the next step would be Botox or InterStim. Or should you assess to see if they have more of a stress incontinence picture? Maybe that's why they're not getting better. It's not that the urge treatment didn't work. It's that the stress component is now the predominant problem, and you might see that on your urodynamic study. Some more didactic stuff. This basically looks at the different types of incontinence that can be associated with mixed incontinence, and if it was predominant urge, bottom line is they seem to be more severe. The patients seem to be more bothered by patients with the more predominant urge component than the more stress component. A lot of times when patients have an unstable contraction, they'll have an involuntary loss of bladder volume, and a lot of times it's the full bladder capacity. So again, a lot of times you'll see they go through more pads per day. They have higher volumes of urine loss. Your urodynamics is not going to be able to help you identify by the definitions. Mixed incontinence is such a nebulous topic. This is a good. I actually like this one. This is one of my favorite slides on mixed incontinence. This is looking at two different UITN trials. UITN trials is the Urinary Incontinence Treatment Network. These were the sister trial and the B-dry trial. The sister trial was women who presented with complaints of stress incontinence who wanted stress incontinence surgery. They had to want stress incontinence surgery to be enrolled in the trial. So that's fine. Then they got these validated questionnaires that we gave them, and then we adjusted the thresholds for what would be urge versus stress versus mixed. So there's no perfect questionnaire, and depending on how defined or how tight you made it, these patients had a definition of mixed incontinence. If you made it really tight, only 8% had mixed incontinence. The other 92 would have had pure stress. On the other hand, if you loosened the range a little bit and you change what you said would be an urge incontinence component, then it was 93%. So 8%, same population, all women were planning on having stress incontinence surgery. Depending on how you defined it, these patients either had 8% of them had mixed incontinence or 93% had mixed incontinence. But remember, these all women thought they were pure stress incontinence because they were going to come in for stress incontinence surgery. The B-dry trial was the opposite. These women were coming in with overactive bladder urge incontinence, and they wanted medication, behavioral therapy for their urge incontinence. And then depending on how we skewed the questionnaires, 64% were mixed versus 97% were mixed. Same women, just depends on how you ask the question. So it's real nebulous, and I've certainly seen women with urge incontinence come in, mixed incontinence come in and end up having a sling done, and the sling really isn't what they needed, but depending on what you were fixated on, you heard them say stress incontinence, and it makes it more difficult to diagnose them. This was another evidence or prevalence study looking at different types of incontinence over time, and you can see the red is stress incontinence, and as you get older, it tends to peak at around mid-50s, and then the kind of incidence goes down a little bit. Pure urge incontinence is the darker green, and this does the width. Kim, can you see my arrow? I'm hoping you guys can see it. The width of this pure urge component gets wider.
I do
Is
see
that
the
showing
arrow.
up, Kim? Can you hear?
Yes, I do see it.
Okay, great. Excellent. So you can see here, pure urge is this wide over here, and it's this wide over here. So it does increase with age, but look at the light green, which is the mixed incontinence. That one clearly gets more prevalent as you get older. In fact, again, in my practice, it's rare that I see a pure urge and a pure stress, especially in women who are, say, over 60 or 65. Most of them do tend to have urge, but again, that's my practice. I probably have a skewed practice. They tend to be older, more common after age 55. They do tend to have other health factors. If you looked at women who had diabetes, they were more likely to have mixed versus urge versus stress. If they had previous bladder surgery, they probably more likely to have mixed versus urge versus stress. That one kind of makes sense because theoretically, if they had bladder surgery and then we're implying it's some sort of stress incontinence surgery, they didn't get better. If they still have incontinence, they didn't get better. What are they more likely to have? They probably had the urge component that didn't get better. And you can see the race and ethnicities. If they're Caucasians, urge is equal to stress. If they're African American, then urge is often worse than stress, which is often worse than mixed. So how do we approach the patient with mixed incontinence? The traditional approach has always been treat the component that bothers the patient the most. The conservative approach is initiate therapy that's the least invasive. And then if you're a surgeon and you think you need to cut to cure, then you treat with surgery first, and usually that often is the SUI, but not always. So the traditional approach is probably, at least in the circles that I live in, these people I know, they tend to do the component that bothers the patient the most. But there is no real evidence to support that. A lot of times it's dictated by the provider. I believe it, so that's what I tend to do. On the other hand, if you have a provider who's a non-surgeon, that'll often dictate the care too. So if I'm, say, a primary care provider, nothing wrong with being a primary care provider taking care of mixed incontinence, but you're not going to be able to offer your patient a sling, and she's looking at you right in front of you and says, I have mixed incontinence, you may be more likely to put them on an OAB med or treat them for their OAB part or do non-surgical options for their stress incontinence, because surgery for stress incontinence isn't in your armamentarium. It's not bad, it's just it often may dictate how you go. So the AUA came out with guidelines for urodynamics. We've reviewed these in the past, and these looked at the various different types of urodynamic tests relative to the different conditions. Now, in summary, because I'm going to go over a couple slides in a minute, but in summary, we know that when women have stress incontinence, they pretty much don't need urodynamics. If they have straightforward stress incontinence, they don't need urodynamics. It's really meant to be for the women who have more complicated stress incontinence, the redos or the recurrent stress incontinence with a neurologic component, stress incontinence with impaired emptying, or mixed incontinence, stress incontinence with an urge incontinence component. So we'll see how they affect that. And then the other way is true as well. For the overactive bladder urge incontinence patients, they don't usually get urodynamics either unless they've tried and failed a couple lines of therapy, and now you're looking at, are they looking at more aggressive therapy, or should you be doing urodynamics first to make sure you got the diagnosis right before you proceed? So the guidelines were meant to kind of to help steer through that, but again, pure stress, not necessary. Where it does give you the leeway is if you have the complicated patient. If you've got the complicated patient, you need to document, then multi-channel urodynamics is a good idea. You want to start with a post-void residual. You don't do it for straightforward, but you do it for the mixed patients. And if you're going to do it for the mixed patients, then you should assess urethral function. And if you don't see the stress incontinence, remember to refill and then do another Valsalva test, but take the urethral catheter out. Again, sometimes people don't leak with the catheter in, but they might when the catheter comes out. If you're dealing with a female who has prolapse, you want to look for what's called occult stress incontinence. These patients may have a kinked urethra, so they don't leak when their prolapse is down. These patients may have urge incontinence and no stress incontinence, but they come in with bad prolapse. If you reduce the prolapse, you unkink the urethra. Now they've got urge incontinence, occult stress incontinence, which you just unmasked, and then they also have the prolapse. They may have all three. So that's a good thing to do because you want to identify those patients ahead of time. For urge incontinence, again, these would be the patients who have failed, most likely would have failed a first or second line OAB therapy, and you're kind of, I'm not sure what's going on. Before I start embarking on more aggressive routes, I really want to confirm that they have the cause. That's a debatable issue because there's a lot of women who don't have overactivity but still have urge incontinence. But there's other things that can cause urge incontinence as well. Altered bladder compliance, it's more often a neurologic problem or neurogenic bladder problem, but you'll see it in women who've had previous pelvic surgery, previous radiation therapy. You may have someone with a neurologic problem and not realize it, or you may be seeing someone with, say, MS or poor diabetes and they have altered bladder compliance. Those can contribute to or cause urge incontinence. You also have the possibility of someone with urge incontinence who had a previous sling. You want to make sure they're not obstructed. So that's where you do what's called a pressure flow study, and you want to make sure that their flow rate is reasonable and their pressures are not too high. So how does urodynamics help you if you go through this? Well, unfortunately, it's more of a no clear-cut findings going to like steer you into making things clear or not clear. And what I mean by that, it's part of your whole presentation. Will you see specific urodynamic differences? if you had a patient with mixed incontinence versus urgent incontinence, you'd be more likely to see the true overactivity. But just because you don't see the overactivity doesn't mean they don't have it. That's my point there. If they have mixed incontinence, they're more likely to have a little higher voiding pressure. But the difference between 16 centimeters of water pressures and 21 centimeters of water pressure isn't that high. So there are really not that many urodynamic findings that are going to say, oh, this is an obvious mixed incontinence picture, this is an obvious urgent incontinence picture, this is an obvious stress incontinence picture. On the other hand, what you're going to be using the urodynamics for is to really rule in, rule out, make sure they don't have something bad, and compliance would be the worst one. Or you got the patient with stress incontinence and she's got such severe overactivity that you're looking at her and it's like, I don't even see how you could have stress incontinence because you can't hold more than 30 cc's in your bladder. So that's where urodynamics will help you. But if you're looking for urodynamics to have like a, oh, there's the result, it's an obvious mixed incontinence picture, you're not going to see that. So it's not the performing, it's really using how you're going to use the data to guide you, and hopefully with the case presentations we'll get there. I can't tell you that urodynamics really makes a difference in the treatment plan. What I mean by that is if you you're looking at urodynamics to tell you that one treatment is better than another, it's not going to do that. A rare exception with anecdotal stuff, we'll go over it in a minute. But for the most part, if you think you see stress incontinence in a mixed incontinence picture, you're going to be treating the stress however you would want to normally treat the stress. We'll go over that now. So how did mixed incontinence impact actual treatment? So if you were treating your patient with medications, there was something called the duloxetine trial, which was a medication for stress incontinence. It never made it to FDA approval in the United States, but the data is worth looking at. It did improve stress incontinence. It did not make a difference if they had mixed incontinence or stress incontinence, and patients with urodynamic evidence of mixed incontinence didn't make a difference. If you're looking at the overactive bladder studies where they had urgent incontinence versus mixed incontinence patients, the bottom line is none of these studies actually included a urodynamic component to it, so I can't tell you that urodynamics helped or didn't help make the difference in treatment. As you would expect, the medications are for overactive bladder. They're going to make the urgent incontinence better. They really theoretically shouldn't impact stress incontinence. In the solifenacin trial, you'll see it was effective for both groups compared to placebo. Mixed incontinence versus placebo, well, they made the urge component better, so the patients overall will think they're better, even if the stress part was still there. In the mixed incontinence tolterodine trials, they actually looked specifically at stress incontinence, and it didn't affect it, which that's what you would assume. You're not giving them a drug for stress, you're giving them a drug for urge. But just treating their urge made them happier overall, that their quality of life got better. But again, urodynamics, no role in this trial. For pelvic floor therapy, looking at different forms of pelvic floor therapy, urodynamics, again, really didn't play a role here. Now, if you think about where will you insert pelvic floor therapy in your armamentarium? It's going to be on a first-line therapy, most likely. So urodynamics doesn't usually come into this picture anyway. It's not like you're going to say, oh, I did my urodynamic study, I saw mixed incontinence with overactivity and stress incontinence, so I'm not going to offer you pelvic floor therapy. That's not what we use urodynamics for. More likely, I would offer them pelvic floor therapy, they didn't get better, and then I would do urodynamics to find out why. So bottom line is, for this kind of situation, it's really not going to be that helpful. But same thing for bulky injections, pessaries. Really, urodynamics didn't come into play because we typically try or should be reserving it more for the failed patients. And bulky injections typically are going to be a first-line therapy, or it could be a recurrent therapy, but the data is just not really there to help us. Did it have an impact on how you did your stress incontinence surgery? In terms of outcomes, not really. With regards to stress incontinence, the mixed incontinence, if you did a mid-urethral sling, MUS is mid-urethral sling, really the outcome was the same whether they had pure stress or mixed, which is good to know. It's not what you would intuitively think, because you would think that the urge component would still be there. But we do know that there are some patients who have urge incontinence, and they'll have stress incontinence, and they go through their surgery. You'll warn them that the urge component will still be there, and they got better all overall. this is the slide where I wanted to review for urodynamic changes after a sling, after a mid-urethral sling. You would think that it shouldn't, but actually, detrusor overactivity got better. So in looking at the bottom bullet, you'll see urodynamic changes of mid-urethral slings. Detrusor overactivity resolved in 60% of the patients, whether they had a TVT type sling or a TOT type sling. That's not supposed to happen, but again, these were predominant stress incontinent patients with an urge component, and they did get better. So what are the real questions for you? Can urodynamics guide you to the optimal approach? And the answer to that is not by itself. You're going to have to use urodynamics with the rest of the picture to kind of guide you. I still believe that you should, at least what I do is I go after the more bothersome component too. If they have stress and they have urge, but the urge bothers them the most, then I typically will try the urge component first and try, OAB medication. If they don't get better, then I'm in a dilemma. If they don't get better, it could be because their stress incontinence is the real problem. I respect Vic Nitti. He's up at NYU, and he once said, it doesn't matter which one bothers them the most. If they have a bad urethra, and that means they have bad stress incontinence, even if she's telling you she's got bad urge, you're probably not going to make that patient better until you fix her urethra. So I do use that, even though I just told you I don't. I do use that. I'll offer the patient an OAB therapy first. And if they don't get better, I will be quicker to jump to an SUI treatment than I would if I, say, had a pure urge incontinent patient. They don't get better on meds, I'll go to more meds. They don't get better on more meds, I'll go to Botox or InterStim route. With the mixed incontinence patient and a bad urethra, I'm probably going to be quicker to jump to a sling or an SUI procedure than I would in a non-mixed incontinence patient. Is there an optimal treatment? Can urodynamics help to align that for you? No, not really, other than we've seen other times where urodynamics evaluations that showed possible voiding dysfunction problems. They may do better with a TOT type sling. If they have bad stress incontinence with a low lead point pressure, those patients might do better with a retropubic sling. We went over that on the stress incontinence webinar, but on mixed incontinence, I would just follow the same for each component. So that's it for the didactic part, and I'm kind of glad because I didn't like the didactic part as much this time, but we got cases and we got a lot of them. So Ken, let's open it up for questions on the didactics real quick, and then hopefully there won't be any, and then we can go right into cases.
Okay, so if anyone has a question, raise your hand and I can unmute you. No questions, so.
Okay. So our first case. We have a 57-year-old female with mixed urinary incontinence. She's got urge and stress. She says they're both relatively equally bothersome to her. She wakes up 3 times a night. She's had no nocturnal leaks. She's going to the bathroom about every hour. She's tried tolterodine without improvement. She's diabetic. On physical exam, there's no prolapse. You cannot reproduce stress incontinence. You don't find any other abnormalities. Her urinalysis is negative. Her post-void residual is 40 cc's. Thoughts before I'm not going to open it up yet, but what I probably would be thinking about, or what I hope you guys will be thinking about is, is this patient we can't see stress incontinence on exam. We can't see stress. She complains of it, but she's got a fair amount of OAB symptoms too. So is it refractory OAB? Does she have stress incontinence and we just didn't reproduce it on our exam because she had an empty bladder or she knew you were looking? She's diabetic. With diabetes, you can get a diabetic impact on the bladder. You get the classic diabetic cystopathy, but she probably doesn't have that because her residual is so low at 40 cc's. But she could be a strain voider. The diabetic cystopathy, if diabetes impacts her bladder, she'll have a weak bladder or no contraction, and she may be able to empty only because she's straining a lot. So we'll see. So the first thing you're going to get is you're going to get a diary, but let's say we don't have that. She comes in with her, actually hopefully you will have a diary. She comes in with this Uroflow. She's got a Qmax of 7, Q average is 4, voided volume was 82, and a PVR was only 10 cc's. You'll see this interrupted pattern, which could be straining. The first thing you should probably say is, well, wait a minute. You only got 80 cc's. I know that the voiding flow rate is often impacted by the voided volume, meaning if you don't have enough in there to pee, your flow is going to be low. And that's a true statement. So ideally, we like to see a lot more than 80 cc's in Uroflow. Actually, we kind of like to see 100. One textbook said 150 to 200. I actually only go for 100 because I can't often get patients that high. But I'll take 100 to 200 cc's. And again, the UITN trials that we were part of, we said if you're going to be doing a Uroflow, you got to have at least 100 cc's. So she doesn't even have 100 cc's. Does that mean I got to scrap this test? Well, the first thing, I should say, the next thing you should look at is her diary. Because if her diary says her average voided volume is in this range, you're not going to get much better than this, no matter what you do. You can fill her up. You can make her go home, come back with a full bladder. She's always going to say this is full for her. So how would I interpret this? I would say her Qmax is 7, her Q average is 4, voided volume was 82, PVR 10. She comments are an intermittent pattern. Caution, her voided volume may be low because, her flow rate may be low due to a low voided volume. I can tell you she's emptying well with regards to PVR because her PVR is low. So here's her pressure flow study. So the way my studies are oriented, you got PVES, P abdominal, PDET, one on top of another. Then you got EMG. Below it, you've got fill rates on the very, very bottom. Fill volumes. And then on the top, you've got the Uroflow and the voided volume. And what you're looking at here is two studies superimposed or running one after another. On the first run, we got her up to 45 cc's or 43 cc's. Her first sensation was 22, which was very early. Be cautious when you hear someone say, my first sensation is 22. Your patient says that, ask her or him, are you sure it's a true sensation or are you just feeling a cold sensation? Because cold could be the temperature change from the cold fluid you're instilling as opposed to, if you didn't warm it up. Cold or temperature is not a true bladder sensation. But in her case, 22 was her true bladder sensation. I got to go. I can hold it a little bit longer, so she holds it longer. She says that she's got to go more at 38, and you can see at 38 she's got a little rise in pressure here. That is an initial unstable contraction. And then at 43, she says, I can't hold it anymore. I got to go. And boom. She has this unstable contraction. She tries to hold it. You can see her EMG lighting up there. And she tries to hold it. She can't hold it. And she voids. Or I should say she leaks, because this is her leak. Now, I couldn't even do a cough on her because she went so quickly. So we do another run. We'll empty. She voided to completion. So we did another run, and we did coughs really early. She didn't leak, but I'll tell you now, coughs at this point are so early it doesn't make sense. It doesn't have any bearing on her stress incontinence. And the same thing happened again. We got her up to about 30 cc's, and she has another unstable contraction. She's got the detrusor overactivity. I can't tell you anything about her outlet. I can tell you that her EMG increased, and her pressures were a little high during the void. Could this be the detrusor sphincter dyssynergia? That's a neurologic process. Well, she doesn't have a neurologic diagnosis, and I doubt it she does. I doubt this is dyssynergia, even though it looks like it. What do patients with bad overactivity tend to do? They tend to squeeze and hold it back down there because they're trying to avoid having an accident. And this is what we call pseudo-dyssynergia. Can you tell for sure? There's an easy way. You do another run, a third run. In this case, and you tell her, look, the next time you feel the urge to go, just let her rip. Don't try and hold it. If they have true dyssynergia, they won't be able to suppress the EMG. It'll continue to happen. You'll see it look like this another time. On the other hand, if they have pseudo-dyssynergia, they can relax it, and then they'll be able to go. So it's a reproducible detrusor overactivity. She has low flow, partially because she's probably trying to hold it, which would explain why her pressures are high. partially because she has such low fluid volumes as well. This is a failure to store or a failure to empty, and is it a bladder problem or an outlet problem?
Dr. Kraus?
Yeah.
Kimberly Wright has a question, so I'm going to unmute her so she can ask her question.
Okay.
Kimberly?
Yes, I just wanted to ask about the QMAX 7, the flow, in the first one, yes.
On this one or on this one?
This one.
Okay.
What exactly does that mean, that she has like a slow flow?
So for a female, a QMAX of 7 is real low. Even for a guy, it's real low. Most women will have flow rates in the upper teens and 20s. And women's flow rates will come down with, men and women's flow rates will go down with age, but women's flow rates tend to be more preserved. So let's say a 30-year-old female may have a flow rate of 24, 22. And then at 60 years old, she may be down to 18. It's not that much difference. And that's solely because her bladder may be having bladder changes as she gets older, technically gets a little weaker. Whereas men have a prostate, and their prostate grows. So men will actually, a young guy in his 20s should have a flow rate of about 20. And as he gets older, if he's 57 or 60, his flow rate's usually going to be in the mid-teens. But 7 is weak. 7 is weak for both men and women. And it's low, but in this case, I don't know if she's low because she's obstructed or if she's low because she's not making enough urine. This test, the pressure flow study, tells you, no, it could be obstruction, but she's got a better flow rate here. And it could be because she's holding it back, but I don't think she's got a prostate, or not meant to be a joke. But what causes obstruction in a female? A previous sling, she didn't have that. What else causes obstruction? Prolapse. But if she's been examined, she doesn't have that. So it's most likely she's self-inducing her obstruction by this extra EMG activity that she's causing.
I see. Is the way you know the flow because of the number on the right side, or is there a way in the actual graph that you could see the flow also?
So are we talking about the tracing that's on the screen right now?
Sure. So her flow is 13 here.
Right. So the machine will pick up the highest flow. If you look at this column on the right-hand side, it will pick up the highest number, but I'm going to caution you, it is very often wrong.
Okay.
So, for example, this blip over here that you're looking at is a PDET, and it shouldn't have happened because there was some artifact in it, and that's what caused it. The machine doesn't know the difference. It will pick up the artifact. So if she kicked the Uroflow machine, for example, it would have shown up on the Uroflow, and the machine would have picked it up.
Right.
It will pick up whatever it sees, and then your job is to look at it and say, no, you got to fix that. And there is a way on the machine to isolate just this section, and I'm willing to try and experiment in a little bit because I've got the Urodynamics software on this computer, and maybe I can run it and it'll show up on the webinar. I'm not sure, but we can try. But
Thank you so much.
If I can't do that, then I would say your Laborie rep should be able to walk you through. It's pretty easy. Just it may not be intuitive, but once you see it, it's pretty easy.
All right. Thank you very much.
Sure. So she's a failure to store because of overactivity, and some things to talk about is, she complains of stress incontinence, but I can't tell you she doesn't have stress incontinence because we couldn't reproduce it because we couldn't get enough into her bladder. I can tell you that she's having such frequent detrusor overactivity that she may cough, and she just might happen to have an overactive contraction at the same time, and she'll make the connection, oh, I leaked and I coughed, so I must have cough leakage. Well, no, actually, you had an unstable contraction, and you just happened to cough at the same time, and that's why you leaked. You leaked because of the unstable contraction, not because of the cough. So when I see such frequent DO, I do worry about that, and I will try and ascertain. I'll even ask them, do you ever leak with a cough? And they'll say yes. And do you always have an urge when that happens? And you can sometimes steer them through it. If not, I mean, this lady's overactivity is bad enough that I probably would be going after the overactivity first. The study confirmed that you're likely looking at refractory overactivity, overactive bladder. The voiding is difficult to assess. I'd like to have seen her flow better, but maybe just because she couldn't hold enough, and that might get better if you can make her hold more. That EMG we talked about, very possible to be dyssynergia. And after looking at this mixed incontinence patient and the urodynamics, I would probably aim for a more aggressive OAB therapy, detrusor activity therapy, not pursue the stress incontinence treatment yet. But I would warn her, this is where the urodynamics will help you, again, the counseling part, that I'm not going to shut your stress incontinence, and if I fix your OAB, you may have stress incontinence later. We'll have to fix that afterwards. So, questions on this case? This would be a good time to ask questions now. Okay. Moving on. A 60-year-old female with mixed incontinence. She's had incontinence for over 3 years. She's using 3 pads a day. She also says she's got stress and urge, doesn't think there's a real difference between it. She gets put on an OAB medication, doesn't get better. She's had a previous bladder suspension, abdominal hysterectomy, and a posterior repair long time ago. She's had 5 vaginal deliveries. On exam, you do reproduce stress incontinence. She doesn't have any prolapse. Her UA is negative, and she's had a PVR of 10 cc's. So, should we just pursue the stress incontinence and go after the treatment for that? Or does the urge component spook you, and that should be addressed, or do you want to study her? Well, I have her here, so we're studying her. So here's her urodynamics. Her Uroflow shows she's got a Qmax of 22. To the person who'd asked that question before, what I did here was the machine has the option, and I think it's under events or information, and you'll click that and you can come down and it'll give you the option of voiding parameters, I think it says, or something like that. And then it'll pop up this window, and it'll give you all the voiding parameters in the Uroflow, and it'll also do it for the pressure flow. However, that's assuming the machine knew to look from here to here, and if it didn't, we'll show you how to do it. In fact, you would. This is not a functional button right now, but you would hit this thing where it says options, and it would then tell you where do you want to look, and you would put your cursor from here to here, and it would focus on just that part of the tracing. In this case, that's already been done for you. Her Qmax is 22. Her Q average is 15. That's a normal flow for a female. And in fact, I like to see the average flow to be at least 50%, if not better than the Qmax. So that's the case here. She holds 365. She voided 365. I know she holds. I know she voided 365. I don't know what she holds yet. But that's a reasonable volume, and she has a 0 residual. So far, she's looking pretty good. Now here's her tracing. Her first sensation kicked in at 88 cc's, which is a little early. That's the FI down here. Her capacity was 365, but ultimately we got 437 out of her. So capacity is 437. That's pretty good. I'll tell you that most of the time with OAB patients, they tend to have a smaller capacity. So I'm a little less impressed now with her OAB. Her sensation was a little early. That tends to go with OAB. So her first sensation at 88 is a little early. That fits OAB, but her capacity is normal. She didn't have any overactivity, or did she? I see a lot of these blips. Well, my rule is if you see something here that you're not sure if it's real or not, and I see a blip here too. If you see blips here and you think they could be coming from the bladder, well, if they're coming from the bladder, they have to be in PVES. So you go straight up, and you should see the same event going on. And I look up here, and I don't see this sawtooth pattern up here. I do see a sawtooth pattern in the P-abdominal tracing, and that's why you're seeing them. Remember, it's the mathematical equation is this pink line versus this blue line to give you this green line. These went up, so subtracting it made it go down. Bottom line is there is no overactivity on this tracing. She holds a good amount. She did have stress incontinence. Her Valsalva lead point pressures, I'll give you in a minute, but they were, I can't see it. I have it written down on the next slide. And then she voids, and you can see she does void with a voluntary contraction. It's not very high. She's got a great flow rate. Qmax was 36, but this is, again, to the same person who asked. This machine picks up whatever it sees in this line. This is a spike, and this could be a strain or it could be an artifact. And actually, I think it's an artifact. But it went up to 36. But the machine saw it and said, oh, that must be Qmax. In reality, your Qmax is over here, which is about 24, which is still about par with what our Uroflow showed. So again, that's why you can't just go with that left column, or sorry, right column, because it'll identify anything. Here's her urethral pressure profiles for those who do them. She had a closure pressure MUCP of 46 and 43. So, and then her, I told you I mentioned it earlier, her Valsalva lead point pressures, she had a VLPP of 110, 99, and 100. So is this a failure to store or a failure to empty? Is it a bladder problem or an outlet problem? It's a failure to store, outlet problem. She has stress incontinence with the VLPPs of about 100. She's got urethral closure pressures of over 45. Those are consistent with a normal functioning urethra. We call that genuine stress incontinence, as opposed to intrinsic sphincter deficiency. What does this case tell us? Well, it tells us that sometimes our patients are wrong, even though, or at least they're telling you the wrong thing. She was saying she had urge incontinence, and she didn't have any of it. She was just kind of confused, or she thought she had urge. I didn't reproduce it. This is where it confirmed it, and I'd be aiming for her stress incontinence now. I probably warn her about the risk of urgency after surgery. A lot of times there's a risk of de novo detrusor instability is a term. De novo urgency basically is the symptom. Maybe she'd be at risk for it, but I didn't see any evidence, even though she had mixed incontinence on presentation, I didn't see any evidence of the urge component on the urodynamic study other than that early sensation, and that's kind of weak. So, questions on that one? Okay, moving along. So for the urologists in the community, or the people from urology practices, this is a guy. I actually like this case, probably of all my cases. He's a 79-year-old male with incontinence. He has stress and urge incontinence, wakes up about 3 times a night, has occasional nocturnal leakage. He's had incontinence after prostate surgery over 20 years ago. I saw him in 2010, was impressed by his stress incontinence and put an artificial sphincter in him. If you have anybody who's had an artificial sphincter placed, you know that they are often very happy. I think this guy must have mental disease because he thinks I walk on water, mainly because that sphincter works so good. He loves me. Until this year. This year he comes in saying, Doc, I still love you, but I'm leaking again. I think your sphincter's broken. Difference is that now he's saying he can't make it to the bathroom in time. He still also has some stress incontinence. Sphincters are never, well, not never, but they're not always 100%. So I put him on an anticholinergic medication, thinking that his urge component was the problem. He says he's a little bit better, not that much, and he's on high-dose solifenacin now. He's using 6 pads a day, and he's not happy. When the sphincter was working good, he was using 1 pad a day. So on exam, his sphincter is in good position. It's easily palpable. I can cycle it. It cycles well. You pump it twice, and all of a sudden he's pouring urine out. His UA is clean. His PVR is low. So what should you be thinking about? Is his artificial sphincter failing? Could he have a malfunction? Could he have something called an erosion? Could he have a refractory overactive bladder that just didn't respond to the medication? Really? The guy's had artificial sphincter for all these times, doing great. All of a sudden he's going to get OAB? I don't know. So the next step should be actually, again, I apologize if you're in the Urogyn camp or gynecology camp, you're not going to be seeing this, but I take it back. Yeah, it can be analogous because this could be the patient who had a sling done and is now complaining of incontinence. And now you got to decide if your sling is broken or not. were not working. So for a guy with an AUS, you'd want to scope him, and we did, and we confirmed that his sphincter was functioning fine. There was no erosion. It opened and closed. You could actually see with the cystoscope, you could see the urethra compress and open. Not 100%, but pretty good. So he goes to urodynamics because, honestly, I don't know what's wrong with him. If he's leaking, maybe he needs a tighter cuff on his sphincter. I already showed that it didn't seal tight enough. So here's his Uroflow. He's got a Q max of 12, Q average of 9. He voided 168. His PVR was 2. His Uroflow doesn't look bad, but it does have a low flow. And he voided a reasonable amount. So could he be obstructed? Could be. He's 79 years old. We do know the flow decreases with age, so something to think about. Now here's his study. His first sensation was at 116. That's normal. And then he gets an urge. He gets an urge at he gets a sensation at 116, and then he gets an urge at 116, and then this boy happens. And he can't do anything about it. This is an unstable contraction. It looks like he had one here first, started to come down, then went back up again. And he didn't even have time to do anything. If you know about artificial sphincters, in order to void, he has to squeeze that little device. He didn't have a chance. In fact, the urge came upon him, and he leaked. This is an identification of an unstable contraction that caused him to leak through his sphincter, which is going to happen because sphincters don't stop everything. He did not leak with this strain maneuver. You can see there's no leakage there. So is he a failure to store or empty? Is he a bladder problem or outlet problem? So he's a failure to store. He has complaints of stress incontinence, but I didn't see it on the urodynamics. He definitely had overactivity. So did I miss stress incontinence on that study? Sorry, guys. I must have said he had stress incontinence. He must have had it somewhere, and I just didn't see it on the tracing. So he has stress incontinence, but the detrusor overactivity is the most important part because it reproduced this leakage, the symptoms that's bothering him the most. Sphincter's not perfect, but it's still working the way it was, and he needs treatment aimed at his overactivity. Now, he failed meds, and what I would do is I would aim my treatment gun at his OAB component. Now, he's already been on high-dose anticholinergic. That didn't get better. I put him on the beta-3 agonist. That didn't get better. I put an interstim in him. That did get better. And he is now happy as he was before. Leaking about a pad a day, a little bit of stress, no urge now, and he's happy. Questions?
No questions.
Okay. Back to women. I think that's the only guy. 61-year-old female with mixed incontinence, stress and urge, wakes up 5 times a night, has occasional nocturnal leakage. So right off the bat, when I hear nocturnal leakage, they were sleeping, they're leaking in bed, they're not, unless they've got asthma or some COPD problem, or lung problem, they're not coughing and sneezing in bed, they're not lifting heavy things, they're not exercising. Nighttime leakage while sleeping is my poor man's test for overactive bladder. And I'll use it. It's actually usually right. But she's got frequency, she's got urgency, she's waking up, so she's going to the bathroom about every 30 to 60 minutes. You tried her on sulfenicin, no, not better at 5 milligrams. You put her up to 10, and she does not tolerate it, so she's got to stop it. She's diabetic. On exam, she's got no prolapse, she's got no stress incontinence, no abnormalities, and her PVR is also negative, or UA is negative in PVR 40. So here's her urodynamics. Q max of 8, Q average of 4, weighted volume 82, PVR 10, intermittent pattern. Did I see this one? I don't know. Hold on, guys. I think I redid a slide. Give me 1 second. I apologize. Yeah, I misplaced the slide. I apologize, guys. Here's her urodynamics, so don't go by the Uroflow. Her urodynamics is here, and she has bad unstable contractions. Capacity 55, 45, 28. Remember what she said. She says she's got stress and urge, but she's got that nocturnal leak. This tells me she's got overactivity. This is that example we saw earlier. This is another example of someone who's got such bad overactivity that I can't tell if she really does have stress, because whenever she has a contraction, she leaks. They're occurring so frequently that they may not. She's making the connection that when she coughs, she leaks, but she just happened to have a cough. She more often is having unstable contractions. So she's a failure to store because of her overactivity. Weak flow again might get better if you could actually get her to hold her more. She's saying she's got stress incontinence, but she really doesn't. She's got overactivity, and there's no diabetic component to this study. This study is very similar to that other one. In fact, I probably mixed them up. I apologize. So I hope you have no questions for that one, because that one is very similar. My next case, 64-year-old female with incontinence, wakes up 3 times a night, frequency, urgency. She can't tell when she's leaking. She says that she doesn't have stress incontinence. She's tried oxybutynin, didn't get better. She had stress incontinence surgery 5 years ago. Her hemoglobin A1C is 8.7. She's diabetic. On the other hand, you do a pelvic exam and you do see stress incontinence, even though she told you she doesn't have it. No prolapse. Her UA is negative. Her PVR is 17. Thoughts that be sure running through your head. Is her diabetes the problem? Does she have stress incontinence surgery? Did she have stress incontinence surgery that was a failure? Did the other stress incontinence surgery obstruct her? Is she too tight? Well, her Qmax is 23 and her Q average is 16, so it's unlikely that she has an obstruction. We'll know for sure in a minute when we do her study. She avoided 215, her PVR was 2. Here's her study. This lady is probably holding too much. Capacity is over 500. There is no overactivity. Qmax was 19. She did have stress incontinence with those Valsalva maneuvers. Her Qmax was 19. Her voided volume was 500. She had a flow of 22. Failure to store. She has stress incontinence, even though she didn't really have it. Confirmed it. She's not obstructed, and there's no evidence of diabetic cystopathy. So here you used your urodynamics to kind of rule out that the other sling had caused a problem. You ruled out that diabetes wasn't causing any issues, and you kind of put her symptoms into a reality check that even though earlier she says she doesn't have stress incontinence, her leaking is really stress incontinence. She's just not describing it well, or she tells you she leaks when she can't tell when she's leaking until it's too late. But there, for whatever reason, her response to the questions aren't being adequately relayed. A 62-year-old female with mixed incontinence. We're almost done. I think I got one more case after this one, and that's actually another good case. Frequency, urgency, wakes up 4 times a night. She's got urge and stress. She gets put on oxybutynin for 3 months, doesn't get better. She gets a second drug added on. She doesn't still get better. She had a bladder suspension many years ago. She's diabetic. No stress incontinence on exam. PVR is 19. What are you thinking? Could this be the previous surgery was too tight? Could it be diabetes? Could she just have refractory OAB? So her Qmax is 30. Her Q average is 19. Her voided volume is 228, and her PVR is 10. That's a nice looking flow pattern. So here we see she holds 163 at the most. This is 2 separate runs again. Here she's got 147 capacity. Her first sensation was 62, much too early. She has what we call terminal detrusor overactivity. This is an unstable contraction. She doesn't say, I got to go, please let me go. She says, I got to go now. Here's her urge. And her urge is occurring at the same time as this contraction. We call that a terminal unstable contraction. It prompted her to avoid her leak. When she does go, she produces a Qmax of 22. Her pressures are low in the 12, anywhere from 12 to 20 range. Usually it looks like 12. We tried it again just to make sure, and sure enough, it's reproducible. Failure to store or empty. Store, overactivity again. She doesn't have diabetic problems. She's not obstructed from her previous surgery. Her other surgery did not fail. She has refractory overactive bladder. This is a case where you don't think the sling is really a previous suspension or bladder suspension is causing a problem. So you can continue going after the OAB. Again, if you want to pursue more meds, you should do so. If you want to try Botox or an InterStim pathway, I would think you would do well with this patient. And I know we're on the end, but this is the last case, probably one of my most humbling ones. 45-year-old female. Stress incontinence, urgent incontinence, goes over 20 times a day, has nocturia up to 8 times per night, leaks with urge and stress. She can't tell you which one's better or worse. She leaks every day. She leaks every night. She's already on solifenacin 10 milligrams and not better. She's diabetic. She's on the medications we talked about. On exam, she's got hypermobility, but she's got no stress incontinence and her PVR is only 10 cc's. UA is negative. No infection or anything. So what do you want to do? Well, her symptoms were so out of whack and her age was so young that I scoped her first, actually. I was looking for something that I wasn't, in case she was some weird problem. Her cysto was normal, and as often happens, her formulary switched her to a different medication because her prescription plan wouldn't pay for the other one. So now she's on oxybutynin, and it was titrated up to 20 milligrams. So she went from, I guess, what did I say, solifenacin 10 to oxybutynin extended release 20. You do her urodynamics, and I have no tracings for you because I'm embarrassed. Capacity is 600 cc's. She has no stress incontinence whatsoever. She has no detrusor overactivity whatsoever. She has a Qmax of 24, but no real contraction. She's straining. No contraction visible at all. And she's got a PVR of 10 cc's. Just to make it a little more interesting, by the way, she was able to continue on the solifenacin, and she's on oxybutynin. Now she's on a whopping dose, and she's still not any better. This is where you should look back and say, something is just not making sense. What isn't making sense? What do you want to see? And Kim, let's open up if they want to ask, jump in on now. You can. It's almost done, so we can do a free for all. Anybody want to chime in what you want to get, or what I should have showed you earlier and forgot to because I was in such a hurry when I did her test? Come on, guys.
Raising their hand.
What should everyone have before they go in for urodynamics?
Oh, here's somebody. Vicky?
Yes.
What would you like?
I was just trying to guess what it would possibly be.
What'd you guess? I didn't hear.
I typed it in. I said something like that in oxybutynin might have numbed the bladder even more. She's doing a lot of pushing and straining with no...
Yeah, that's sure what happened. But I can't explain why she's going to the bathroom so much. That's why we were pushing the meds on her.
Did she empty?
She emptied all the way.
From straining.
With straining.
Yeah.
But she had a low, but PVR 10 or so.
So her youth did that for her.
Huh?
I notice in youth they are better strainers than the
They are
elderly.
better strainers. I agree with you. I agree. So do you do your own urodynamics?
Yes, for Georgia Urology.
What do you guys get anything before they come into the urodynamics room?
Example, what's the question?
What I'm looking for is they should have a UA, and they should have a diary.
Correct.
And I was in such a rush that I didn't look at her diary, and I didn't look at her UA. I took someone's word for it that it was negative. It was negative because the person who was looking at it was looking for infection, and it was negative for infection. Well, there's her diary. Her daily fluid intake was 5 to 6 liters. her average voided volume was 400 cc's. She's voiding 15 times a day because she was making 4.5 liters of urine per day.
Right.
That's a lot of urine.
That's a lot of water.
That's a lot of water.
That's a lot of
Why
water.
would someone drink 6 liters of fluid a day?
Maybe being a diabetic.
And I wish you were here when I saw her, because there's her numbers.
Yep.
Her hemoglobin A1C was 12, and she had high sugars, and bad on me for not picking on up that earlier. So I can't really tell you it helped, but it did rule out other causes.
Right.
But at the end, it just, something didn't make sense. So
I do notice that if I have a patient that pushes and strains a lot, that the body really can't tell what kind of pressure, whether they're having a bowel movement, coughing, laughing, anything like that, if the body doesn't know to relax or hold. And I usually tell my patients just try to empty more frequently, don't get that full.
And that's what I tell patients too. If I've got patients that are with either bad diabetes or they have to be on high doses of anticholinergic, that they can't tell sensations, I'll tell them to go by the clock.
Yep.
I'll tell them to make sure that I'll give them a urinal, a hat, and tell them, if you're getting 500 cc's or more every time you pee, you got to go more often.
Yeah, that's a lot.
All right. Well, any other questions, guys?
Ryan Novak has a question. Ryan Novak.
Oh, no, those weren't questions. Those were just answers to his questions that he was asking earlier.
Oh, sorry. Unfortunately, I can't see them right now. Let me see. Were they relevant, or were they not relevant? Were they pretty much online what we were talking about?
That's right.
Okay. I'll get them after we're shut down. Any other questions? All right. Well, I hope it was interesting. I hope the cases helped you. Please let me know, because again, I take your comments seriously. If there's stuff that you didn't like or something that you would like to see, and I will, tweak it and make it better for the next time. It also helps other people, in terms of making their presentations better. So, again, I appreciate you staying on, and I hope it was worthwhile, and hope you learned something. Everybody have a good night.
Thank you. Good night, everyone.
Kim, you still there?